Right, thank you everyone for attending today, the Health Scrutiny Committee, the 10th of September 2024. Thank you to all the external partners that are here today, representatives and presenters. We've got from KGH, we've got Julie and Polly presenting on the rebuild and the quality report, and Ellie from the ICB. A few notices before we commence. The report, this is for members, the report on the KGH rebuild only came in on Friday. I hope members had a chance to read it. There'll be no key lines of inquiry on this item. It'll be open scrutiny due to the limited scrutiny permissible on this item as a consequence of the Chancellor's recent announcement. Secondly, I'd like to remind members this meeting is being recorded for public viewing, and there may be members in the public gallery also. Finally, and for the benefit of the visitors, the structure of this committee is to put forward the questions after your presentations, the key lines of inquiry after your presentations, and then open it up to the floor for further questions by members. Recommendations will be relayed after each item's conclusion. On to the first item on the agenda, the apologies for absence. Raj.
Yeah, we have Councillor Matt Keane in attendance as a substitute member.
It is important there is cross-party input into scrutiny, so I am here to represent the Labour Party tonight because my colleagues do not have confidence in your chairmanship.
Okay, thank you, Councillor Keane. Any further apologies for absence? Okay. The second item on the agenda is the members' declaration of interest. Any members declare an interest on any item? Councillor Lorman.
Thank you, Chairman. Yeah, items 4 and 5, it is on the website, but I'm a public governor for Kettering General. It's not a position that holds control, so I have only a personal interest.
Thank you for that, Councillor Lorman. Any other members have any declarations of interest? No, thank you. On to agenda item number 3, the minutes of the meeting held on the 9th of July. Do we accept those minutes as stated? Thank you. Can everyone just indicate? Yeah, superb. Thank you. Okay, on to the next item. Item 4, the Kettering General Hospital NHS Foundation Trust Quality Report. And Julie Hogg is presenting this. Over to you, Julie.
Thank you, and thank you for the invitation this evening. My name's Julie. I'm the interim chief nurse covering Kettering at the moment. It's week 8 in post for me, so the report that you have before you is work that was completed before I arrived, but I think it presents a good story of improvement where you can see improved access to services, whether it be the emergency care pathway or planned care, an improving position with our quality metrics, so infection prevention control assurance metrics have improved. We have adopted the workforce safeguards that are published nationally by the NHS to ensure safer staffing across the organisation, and there are some examples of service innovation such as the one-stop urology service and the breast pain pathway that show real examples of innovation to bring that into the hospital. There are also a number of national and local awards that the team have been recognised for, and we've increased our research within the organisation, and there's really strong evidence that shows that research-active organisations provide better care for patients and a better working environments for colleagues. In terms of areas for improvement, we had the CQC in at the end of the year to assess our paediatric services, and they changed the rating of paediatric services from inadequate to requires improvement, and we continue on that improvement trajectory. The maternity service was inspected and their rating moved from good to RI, and that was on the basis of staffing, timely triage and oversight of services. And we've joined the National Maternity Safety Services Support Programme to ensure that we learn from best practice and make sure that our services are as safe as they possibly can be. And we continue to work with colleagues across the emergency department to ensure that we implement the must-do and should-do actions that the Care Quality Commission gave us to ensure that care is as safe as it possibly can be. We made good progress with the patient safety priorities and the patient experience priorities alongside the clinical effectiveness priorities, and you have before you the priorities for the coming year as well. So I'll leave it there because you've got the report and happy to take any questions.
Thank you, Julie. I'm going to kick this off with talking about some of your strategies and initiatives. But before I get to that, I asked this at the Chair's briefing, and I hope you've got an answer for me today. It's been reported, and forgive me if my numbers are slightly wrong, that around half of KGH patients are waiting longer than 4 hours to be seen and or admitted or discharged. This is above the national average, which is on target to be around 95% of A&E patients within 4 hours. And there's some cases, increasing cases of patients waiting longer than 12 hours. What is your strategy in improving A&E capacity and efficiency? This is something that constituents have raised with me time and time again.
Yeah, thank you. And timely access to emergency care is a real priority for us. So we know that unfortunately the position nationally is very similar to Kettering, if I'm honest. So we are seeing increasing waits for beds and increasing waits to be seen by the specialty, which is the 4-hour target. We have got a robust winter plan that starts with flow into the organisation. So are the people coming into the emergency department coming because they absolutely need to come, or are there other places, urgent treatment centres, GP practices, pharmacy, where they could go? Because we know that the minute A&E departments get very full, they become slow, they don't process patients as timely. We know that affects the timeliness of care. So the first bit is, how do we provide what we can outside of the hospital, and we're working with system partners to do that. The second bit is flow through the hospital. So how do we make sure our processes are as slick as they possibly can be? So timely triage of patients when they arrive. If they need to be seen by a specialty, timely review by that specialty, and a decision made for the patient to go into a bed and for there to be a bed available. And then the final bit is timely discharge. So we know at any given time, approximately 10% of patients in our beds don't need to be in an acute bed. So how can we work with with local authority colleagues, our integrated care board, to move patients onto a more appropriate location for them to be, whether that's in their own bed or in an intermediate bed for those patients that have complex discharge. For those that are going to their own home, how do we make our processes as slick as possible so that they go home, they get their drugs to take away, they get their discharge letter, and their loved ones are able to take them home. So the plan is in 3 stages. It's got executive oversight, and we've got a really good team focused on that and learning from others as well, but we're working across health and social care to do that.
Okay, just a quick follow-up. So are those plans being put in place as of, as we speak right now, as we're getting into winter and things will become a lot tougher? David wanted to come in.
I think I can speak on behalf of system partners, saying the planning never stops. So we're constantly thinking about the challenges. Whilst winter pressures is one thing that is being talked about for a number of years, it's been whole year pressures within the system. I just wanted to give a couple of really tangible examples of where we have worked closely as system partners, using ICB funding, using some of our resources. So one example being taking over the running of Thackley Green. 35 of those beds are used by social care. 16 beds are used by the NHS, funded by the ICB. Most recently, KGH have been working with West Northamptonshire Council on utilisation of the Spinneyfields beds in Rushden. So we're constantly thinking about what are the steps that we need to take to deal with some of the challenges that we've got. And those challenges might be about patient demand, or as it's the result of Spinneyfields, it might be as a result of the rack concrete challenge which you've got in the building. So we're constantly working together to say, how can we improve elements around that? We equally work on some of the practical activities that happen in people's own homes. So trying to improve our reablement pathways is a key element of that, and we're constantly looking at new ways of doing that, but also what do we need to invest in order to make our resource go further. So one example of a pilot which we piloted within our adult social care reablement service, which frees up some of that capacity, is a system called Genie Connect, which actually has significantly reduced people's reliance on longer term care and support, which means that we have more resource available to spread across some of those additional people that we've got coming through. Does it remain a challenge? Absolutely. Is it something which is entirely within our gift as a local system to fix? Not entirely. There are much bigger conversations that need to happen nationally around how do we fix our system for the longer term.
Thank you, David. There are things such as admission avoidance and hospital at home virtual wards that are done elsewhere. So I think that will be a thank you for your answer. Okay, on to thank you as well, Julie. On to some of the themes. So around learning disability and autism strategy, your freedom to speak up initiative and dementia initiatives in your Johns campaign. The report mentions the mandating of the Oliver McGowan training and the recognition of one LD and a nurse. Can you explain, Julie, its long-term strategy to ensure adequate staffing and support for patients with learning disabilities and autism?
Yeah, thank you. So I think this begins with ensuring that actually our staffing across the organisation is in line with the evidence base. So I mentioned our alignment with the workforce safeguards, and that's the national guidance. So the first bit is, have we got the right number of colleagues and is the skill mix right? The second bit is to start to think about the populations that those areas are serving, because actually we will have a team of specialist nurses that support learning disabilities, support dementia care, support mental health, but actually you have to have a level of training and competency across your whole workforce. It can't be reliant on the few that are in those specialist roles. So it's about having the right numbers of colleagues in place. It's about ensuring that they have the skills and competence to look after patients that need reasonable adjustments. And it's about making sure that the environments that we care for those patients in are appropriate and that we adapt the support that we offer to those patients. So it might be appropriate to have somebody stay with them, for example, in a setting where we wouldn't normally do that, or to pre-plan their admission in a way that we wouldn't do for other patients. So I think it is really about the reasonable adjustments and making sure that we have got a good level of competency and training amongst colleagues. Yeah. And a recognition where people feel able to say, actually, I don't know what to do, and to know where they can get help.
Thank you. Thank you for that. Two other questions which I'll ask you together on other members to come in at this point. Could you provide more detail on how the freedom to speak up Guardian and champions are addressing staff concerns and how these efforts are improving the overall culture of safety and openness at the Trust? And secondly, the report highlights the implementation of the Johns campaign. Are there any additional dementia care initiatives planned for the coming year to further improve patient care in this area?
Thank you. So in terms of culture, I think culture, we are on an improvement journey. That's true at Kettering. It's probably true of the wider NHS as well. And I think freedom to speak up is just one method of changing the culture, because actually there's a couple of freedom to speak up guardians and champions, but actually the people that really drive the culture are the frontline colleagues and their immediate line managers. And myself, the Chief Exec, and many of the other executives meet regularly with the Freedom to Speak Up Guardians. So the idea of Freedom to Speak Up is that they have a direct line to an exec or the Chief Exec so that they can resolve any issues that are raised, particularly in relation to patient safety, in a really timely manner. So from my perspective, it's ensuring that Freedom to Speak Up have a voice, that the whole board is cited to the concerns that are being raised, and then you are putting steps in that actively change some of the concerns that are being raised. So in the main, what we hear at Kettering is about the middle management tier and perhaps their leadership of colleagues within the service. Many of them relate to colleague concerns rather than patient safety concerns at the moment. But I think, the culture piece is about a top-down piece where we role model the behaviours, we set the values that we want across the organisation, and we give colleagues a voice through a range of mechanisms, whether it's freedom to speak up, it might be the staff survey, it might be shared decision-making forums, etc.
Thank you, Julie. I forgot to mention these are fantastic initiatives. Thank you. On to the second point within our key lines of inquiry, Councillor Jackson.
Good evening. I have 3 questions regarding staff recruitment and retention. Question 1 is, given the significant improvement in recruitment rates, what measures are in place to retain the newly recruited staff, particularly in high-need areas such as LD, NA and dementia care? My second question, what strategies is the Foundation Trust implementing to maintain or improve upon the current levels of recruitment? And are there any particular challenges that need to be addressed in the coming year? And my third question, what is your current level of staffing and what challenges exist in this area? What specific measures are you implementing to address the issues of staffing regarding funding by using agency staff and normal full-time staff?
Thank you. So if I take the last question first, because I think that's probably a good place to start. So at the moment, if you look at our vacancy rates, it varies depending on what sort of nurse or healthcare support worker it is and where they work. So in the main, our vacancy rates are around 10% for registered nurses. They're a bit higher for paediatric nurses, and that's not unique to Kettering. That is a nationwide issue that we've got within paediatrics and neonatal services. If you look at the metric that we use to look at whether our services are safe is care hours per patient day. And the national average for care hours per patient day is about 9 hours per patient day if you look at it on an organisational level. At Kettering, it's 11. So, if anything, it's probably a little bit too high at the moment. But I think that offers you some assurance that we are filling out those vacancies with temporary staff. We are in the main filling them with bank staff. We don't use much agency at Kettering. We only use it where we have got vacancies within key services that have got significant vacancies. They are in the main paediatric and neonatal services, and you will be cited to why we would go to agency in those services. In terms of how are we keeping people that we have recruited, we're developing a recruitment and retention strategy, but essentially Kettering have over the last year been developing something called the quality framework, and that is all about creating the best possible practice environment for colleagues so that they flourish and patients then get the best possible care. And the key domains of that are around shared decision making, so making sure that everybody in the organisation has a voice, that you have good leadership and good leadership development, that there is professional development, so colleagues who join have a career irrespective of which profession they are, and they can enter any of the 5 career pathways, which are education, research, digital, leadership and advanced practice. It's about well-being, so we all know these are high-pressure environments, so ensuring that colleagues are supported to be well when they're in work and that they're safe when they're in work, free from abuse, etc. And then just looking at the overall care that is provided to patients, because in the main, people that, in healthcare, we don't go to work to do a bad job, so people get satisfaction from providing the best care for patients. So having really good oversight of the quality and safety of the care that's provided, so colleagues feel when they go home they've done a good job. So that's the framework that we are doing, we are using to make sure that we've got the best practice environment at Kettering. I think your final question related to the financial challenges. So by adopting the workforce safeguards, we are aligning ourselves to the evidence base, and that is the nationally endorsed evidence base. So if we set our staffing levels within that evidence base and we fill those shifts to the evidence base, that is entirely defendable and to anybody that wants to look at our staffing. If we are going beyond those or staffing using expensing agency staff, that's when we are wasting taxpayers' money and when we need to be thinking about how we do things differently. So my approach is to remain within the evidence base to make sure that we are getting value for money. And this is my 3rd chief nurse post, and I've found that where I've done that, I've got support from the board of directors to maintain safe staffing across the services. and that means that patients get good care and colleagues have a work environment that is conducive to being somewhere that they want to stay.
Do you have a follow-up, Councillor Jackson? No problem. You have a follow-up to this? Okay, Councillor Lorman.
I'll use a bit of insider knowledge. One of the things that used to exercise me when I was first a governor was that there was consistently inability to hit the 85% target for doing appraisals of staff, and of course what that meant that you just didn't know what the staff thought and what their approach was, and a lot of other information. The IGR's got longer and longer, so I don't read all that. How are we doing with, and you may not be the right person to answer across the whole hospital, I know, but how are we doing with getting that, at least that target, which I thought was quite a low one anyway, achieved?
Yeah, so I don't know where we are right now, and I'm looking at Polly in case Polly knows. What I do know is that appraisal's all about it being meaningful, and we're just looking at the appraisal documentation and our approach to it at the moment, because if that appraisal adds value, colleagues will want to have their appraisal and managers will want to do it. But from my perspective as chief nurse, it's absolutely my expectation that colleagues do have an appraisal. It's fundamental to keeping them in the organisation and ensuring that they are developed and have got a personalised approach to their own career development, whatever that might be that they want. But that's something that I can pick up after this in terms of the actual number.
Thank you, Julie. David wants to come in.
Thank you, Chair. I just wanted to, make a bit of an offer around the recruitment retention side of things, but also flip that with an ask as well. So the offer is, at the moment, we're doing things like developing our housing strategy, and I'm really keen to do some productive work around what are the real recruitment challenges that we've got across the public sector, and how do we build that into, for example, key worker housing approaches. How do we work with our planners to make sure that when big developments are being developed that we're thinking about how we make sure that there's suitable, affordable housing for those groups of staff, so that actually it's not just about what you do, but it's actually about how we value well-trained professional staff in our area and want to give them the best start for them to settle in this area. My ask is on the flip side of that is, whilst I'm also developing a housing strategy, I've got to redevelop our corporate parenting strategy from a local authority perspective. And I'm really keen to look at employment opportunities across every services provided in the NHS. It may be your back office, it may be frontline care roles, it may be therapy roles. But how do we work together to maybe think about doing a project piece of work to say, what are some of our difficult roles to recruit to, and how do we perhaps create supported internships, more apprentices, but almost give our care leavers the opportunity to have an advanced try at those, maybe a protected period of time where they can try before you buy in that sense. So I'm really keen that we try and get our head out of some of the day-to-day churn that we've got and really think about what's the added value that we can bring as public sector organisations in our community.
Deal. So I think, as an NHS organisation, we have an absolute responsibility to be an anchor organisation. So whether that is in the form of employment or where we purchase supplies, etc., how we transport between our sites. So absolutely up for that. I have been piloting strengths-based career coaching in my other role in Leicester. It is brilliant. I think there is something we could do around offering strengths-based career conversation to help get these colleagues into the right employment, and we can absolutely look at doing something.
Thank you, David. Councillor Maxwell, is your question on the theme of staff recruitment and retention? You want to ask about staff? Okay, Councillor Maxwell.
Given the recent striking by nurses, which was a major impact from the residents' point of view, what aspects has that actually had with the staff coming back and And equally, because of the striking, that meant some people didn't get the appointments they should have done. How have you actually moved forward to make sure that they're being listened to, the staff are being listened to? And do they have an opportunity? Is there sort of like a whistleblow situation where if they don't agree with something, they can go and talk to somebody, but it stays there? It doesn't go anywhere else. It just, it's actually picked up and then evaluated, but also respect for the staff, which I think is a major issue.
Yeah, thank you. And I would agree with that. So I think Kettering's been unlucky with some of the industrial action. So everybody's had the junior doctor and consultant industrial action across the country. And that's what's caused maximum disruption in terms of cancelling lots of planned care. Kettering also had the Royal College of Nursing industrial action around the, particularly the Band 5 pay. And that was a national dispute that played out locally because we had enough of a response for it to be industrial action. My learning from that is that the role profiles are currently being reviewed by the national pay body. Some of you might be closer to that than I am, but I anticipate that they will either extend the band, the 5, to allow more progression, or give earlier entry to the band 6. So my commitment is when that role profile comes out, we get on and implement it at Kettering, because that's what our nurses will want and that's what the RCN will want. In terms of the healthcare support worker industrial action, that again was a national role profile change that played out locally, and it played out in Leicester and in Northampton. It would have been better if the national team had given us a solution to that across the country, but they didn't, and what happened was individuals, organisations had to find the money for the back pay and then agree how it was going to be implemented. We have now reached agreement with Unison. I would agree that that was drawn out and took too long, and in the end I ended up in the room with Unison to try and draw that to a close. I think we've found a fair way forward now, and I think we've all learnt a lot. I certainly, in my career, have never seen as much industrial action as we have over the last year, and I think we've learnt a lot that will help us manage it going forward, and in terms of making sure we do have a local response to national issues and don't wait for national colleagues to give us answers, because they may not be forthcoming.
Can I ask another question then? So look at retention, keeping staff on, but then looking at recruiting more staff, right? One thing that I have noticed, it doesn't seem to be feeding down to what I would call the schools. The schools don't seem to be aware of what's available if they want to train to be a nurse. And I think there needs to be more work on looking at, say, sixth formers who may want to become nurses in different aspects of nursing, but not fully aware of what's available. And I think that that's where you could actually have been criticised for the fact of not retaining staff or recruiting them. Is there a way forward in making it so that people are more aware of what aspects, I spoke to a sixth former last week who's looking to go off and do physiotherapy at university, which is great, and but I don't think enough of it is out there telling people what they can actually do and how they can achieve it. Do you agree?
So it's an area that I haven't got into yet with my 8 weeks in here, but I am used to having a relationship with local colleges. So we've got brilliant T-levels now that are in nursing, midwifery, they look at the different branches. And what we need to do is to be able to offer an apprenticeship route from the T-level, because we know that if you have a registered nurse apprenticeship, a registered midwife apprenticeship, a nurse associate apprenticeship, you are more likely to attract local people into those roles, and therefore you're more likely to keep them. So my answer to that would be we need to develop our apprenticeship offer. We have a really strong relationship with Leicester, and Leicester can help us to do that, I believe. And I think absolutely getting out into the schools and colleges is where we should be. And I will take that back as an action for the education team when I get back to base.
Thank you, Julie. So I'm going to have to move on. I'm going to bring you back later on in the discussion. Councillor Matt Keane to ask about research participation.
Thank you. Yes, I've got two questions on research participation. So first one, the report mentions a significant increase in research recruitment compared to 2019-2020. So what steps were taken to achieve this, and how does the Foundation Trust plan to sustain further increased research participation in the future? And the second one is, can the Foundation Trust provide more information on the types of research being conducted, e.g. the quality framework, and how this research benefits patient care? What specific quantities and quantitative research methods are being or will be used, and what percentage of the tools will be being used in person or online to ensure robust training and quality of data?
Thank you. So the research piece predates me by some way, but my understanding is that Kettering has had a joint research strategy with Northampton General, and that looked at growing the programme, the research studies that we participated in as two organisations, so increasing the number of principal investigators and collaborating with other sites to widen the number of studies that are available to patients who are receiving care at Kettering. Going forward, we have an advert is closed today, but there is a group director of research and innovation that is going in across Kettering, Northampton and Leicester. And the strength of that is that it will be aligned with, it'll be three big organisations working to one shared objectives, and that will mean we'll be able to attract not only the NIHR, so the kind of public funding research, but we'll also be able to start to attract commercial research. Alongside that, much of that is medically led research. So you talked about the quality framework, which is nurse-led research. We need to grow our nursing, midwifery, allied health professionally led research. So we have launched something called the Institute for Excellence in Healthcare yesterday, as it happens, which is a joint venture across Kettering, Northampton and Leicester with our provider universities that will become the home for nursing, midwifery, AHP-led research. And I think that will be the key to unlocking the non-medically led piece, because that is the harder piece to do in this. Doctors have research well embedded within their roles. It's less so within the non-medical professions. In terms of the quality framework, so we've developed it, but we haven't launched it as yet. So the evaluation will be ongoing as that programme rolls out. It's being led by Coventry University, so Anne-Marie Carnaby, who is a previous chief nurse, I believe, from, I think, Walsall. I'm looking for help around the room. I'm not close to the research methodology for that, but I can certainly connect you with Tanya, who's leading that piece of work for us over at Kettering, if that is helpful.
Thank you.
Do you have a follow-up, Councillor Keane?
My follow-up question was actually answered. It was about what universities they'd work with, and they've answered that. Thank you.
Superb. Over to you, Councillor Lawman.
Thank you. Actually, perhaps I had the partnership with University of Leicester, who are a teaching hospital, and University Hospital has been the driver for a lot of research, additional research opportunities, should we say. So that's a couple of years now, probably, isn't it? Even a joint chief executive. So one of the most insightful parts of the report actually is the Health Watch, because their report, and they've suggested a lot more information be provided around patient incidents and what comes in the information that's given. I mean, an obvious example is falls, which went up during COVID because of the lack of observation of patients, and predates you, I appreciate. So could you provide a bit more context on any relevant factors and recent trends in patient incidents, and what the causes are and what's being done to prevent them? And then how are you using that data to drive improvements in care, and what steps are being taken to provide more information to people, in other words, to ensure transparency and openness?
Yeah, thank you, really important. And I am absolutely committed to ensuring we're more transparent, not only with our patients and stakeholders, but ensuring that colleagues understand as well. So We had the Nursing, Midwifery and AHP committee this morning, had sight of the harm-free care report, so that covers falls, it covers pressure ulcers, it covers nutrition and hydration incidents as well, and infection prevention. I think Kettering has historically performed very well in relation to pressure damage. We've seen a bit of an increase in some of the moisture-associated damage, and I'm keen to have a bit of a look at that from an external fresh eyes perspective, because we benchmark very well for it. And what I want to be certain is, are we categorising the damage that we've got appropriately and not underplaying it? So that's one part of me wanting to be absolutely transparent and making sure I fully understand the harm that's being done in hospital. In terms of falls, we do benchmark well for this as well. So it's about 3.5 per 1,000 bed days, and I think the national average is about 5.5. In August we had 3 falls with harm, and that is too many. I don't think it's an outlier in terms of where other hospitals sit, but every fall with harm is an opportunity for us to learn. And actually every fall full stop is an opportunity to learn, because people lose their confidence when they fall in hospital, and there are long-term consequences of that, and they end up needing to be cared for by colleagues that are sitting not too far away from us. So there are ongoing pieces of work that we were drawing together learning across the 3 hospitals I've described earlier, to make sure that we've got the best policies and the best prevention in place, that we are really following our risk assessment processes and our care processes that follow after that, to try and eliminate the harm in hospital. I don't think we'll ever get to zero. I think we're starting in a good position, but we have an opportunity to make sure that that position is true, so that we are honest with everybody that we share the data with, and that we continue to strive for improvement. But there are plans in across the board for all the harms that you would expect to see, and we're going through a process of making sure that we are learning from each other, and we're doing exactly the right things we should be doing to reduce harm. And safer staffing's at the heart of this as well.
You want to follow up? No problem.
And to pick up on something, one of the processes that was quite useful, I thought, and Healthwatch mentioned this, was their 15 Steps programme, where they could visit various wards. And according to the report, that's no longer carrying on and not possible. I'm not sure, it doesn't say why, so I'm not sure why. Perhaps you could let us know why it is.
Yeah, I don't know why, but it's in place at Leicester. My intention is to bring it back. I think 15 Steps adds a huge amount of value. We can have our own internal quality assurance rounds, but we can't walk in the patient's shoes, so we do need our governors and Healthwatch to support us with that.
Thank you, Julie. Over to you, Councillor Maxwell, for continuous improvement and future planning.
When looking at the improvements going forward, what are the key issues, do you think, in identifying the feedback from stakeholders? And then how do you actually plan to address this in your next report period of, it would then be, what, 25, 26, won't it? Yeah. Yeah,
so the priorities have been set already. They predate me. I think if I look at what we've been told by the CQC, by what our patients are telling us, by some of the inquests that we've got up and coming, I think where we really need to have a focus on is our staffing. So we've seen some improvement in that, but there are some hotspots that we need to address. Timely access to care, so this picks up the urgent and emergency care piece as well, but that is true through our emergency service as well. It is making sure that we've got risk assessments in place for things like sepsis, but also for falls, hospital-acquired pressure damage, etc. And making sure that we truly listen to patients and their families, so that we learn when we don't get things right, we learn when we do get things right, and that we have them as a safety net for when things aren't going to plan in hospital, and we listen so that we have an early opportunity to intervene. So that's where I would like to see improvement in those key services, so that we are, offering the highest quality of care for all.
So the next question is, when people have something to say. You know, if a person's coming in and has something to say because they're not happy with the way they've actually had their treatment, how are you actually addressing that? Are you actually, I mean, that's an aspect that we get from residents who come to us saying that, well, I went to Kettering General, this didn't happen. So how do you actually plan to actually listen to them? Will it be that do you have forms, or do you have, is there a particular place that people can write to or address it? What's happening at the moment, I think, is that they're not being listened to, some people.
Yeah.
Would you agree with that?
I think I can't disagree with you, because you know the residents of Kettering and what they're saying to you, and I remain relatively new to the organisation. We have got the patient advice and liaison service, but I know that the responsiveness of that service hasn't been where we need it to be, and we are working on that. So that is one way of patients contacting us about a concern. We should answer that quickly, because it then stops patients complaining, which results in much more work. So we need to get that right. We have the friends and family test when people go home, and we seek the views of their experience as part of that. We should have our ward leaders and matrons going around talking to patients and families, getting a view of what their care has been like, trying to resolve any problems that are happening in real time. And I guess the other thing is, I regularly have patients contact me, and I pick up the phone, see if I can help, or a relative. So myself, the chief exec, any of the exec team will meet with people that want to meet with us. We think it's a really important part of our job to listen to patients. So first point of call is the PALS service, but equally happy for them to contact me. And we are looking at our strategy across the organisation to get patient feedback and how we answer it, and leadership, visibility to patients in the clinical environment as well.
I think one of the issues is that when they come into hospital, if, for instance, a parent comes in with their child into the hospital, and then you then say, right, you're going to do a follow-up, and nothing happens. They don't get the follow-up, and then they have to come back on the phone, and the person at the end of the line isn't passing that on. That's the way it seems. And I think parents are getting frustrated, particularly because with children, it's more noticeable, I think, with children, because they do need follow-up. So I think, is there something that you could develop maybe, so that parents have the ability to get through to somebody who will answer their questions?
Yeah, absolutely. I think the PALS service is the first point of contact for that, because they've got access to the senior clinical teams. And we'll think about the single point of contact for that, because for some people an email might be what they want to do, as you say. For others, they want to call. So I will speak to the team that head up PALS and the complaint service to think about how we can be more responsive going forward.
If I may just come in on that as well. So we have done some work this year on a programme that's called Reimagining Planned Care. So that's working across the system with our primary care, with our GPs, as well as community hospitals and with ourselves. And the intention of that's been approved is to create a single point of access that all patients, either from a digital perspective or picking up the phone or what have you, have a single place where they can go that will be able to coordinate what's happening with their follow-up appointments, what's potentially happening with their treatments, where are they, what can be their expectations. So we're absolutely committed to doing that piece of work this year to get that set up.
Thank you. Councillor Lawman.
Thank you. Just to pick up, of the two things I get most contact on, one of them comes under Polly's remit, so it'll be the next thing. The other thing would be PALS, and the speed of response and the consistency of response just isn't there. You get a lot of complaints that they don't get answers, or answers are delayed, or they don't know what's happening. And that's definitely an area where a communication could be improved. So I know that probably doesn't come under you, but what does come under you, again, I think it's in the Health Watch report, they picked up quite a number of cases where people had DNRs and they were still treated. And there's a comment that that's being looked at, but I perhaps we'd like to have some assurance of how that's going. And the third thing, and again, this is probably not yours, but something to feed back. I noticed one of the goals is to establish a new bereavement service, and we know the mortuary is not really up to current standards, but one of the things it says is that they have an aspiration that people will have a call within 2 weeks. That just seems an awful long time to have a call from the bereavement office for support. I mean, it says within 2 weeks, so obviously they would hope it'd be quicker, but I would have thought that support needed to be a lot faster.
I think, yeah, so the bereavement service has now been established, it's in place. I think for me that's a bit of a personalised approach, because some families want to hear, others don't, and there's something about how we negotiate that with them before they leave the organisation. In terms of the PAL service, it does sit under me. I agree with you, it's not consistent, it's not responsive enough. We have a clinically led model at Leicester, which I think helps with timeliness, because you can unblock things in a different way. So I will ask, we'll have a look at that across the group to see how we can resolve that going forward. I think in terms of the DNAR piece and the respect form, which is the advanced care planning piece, that is within our priorities, and we are looking at how we can digitalise that as well, so it is readily visible. At the moment, our digital systems are, I'd say at best, immature across the group. Northampton General are adopting Nerve Centre that Leicester have got. I think Kettering haven't made a decision on where we're going yet, but we urgently need to expedite that, because then, you know, we could have a system-wide view of patients' wishes, because lots of the time these decisions are made in the community and patients then come into hospital and they're having the same conversations again. So it is within the priorities. If you want us to share a fuller detail of the programme in the future, we're very happy to do that.
I think I'm aware of how the EPRs will be going. I sat on the digital committee for a while. So.
Thank you. Thank you, Julie. Any members have any further questions on this item? I want to bring it to a close. No, thank you. And the committee are going to put forward some recommendations. They're on the screen, but I'm going to read them out. So this Health Scrutiny Committee recommends that the Foundation Trust provides a more detailed narrative around patient data in the next scheduled report to Scrutiny, explaining any relevant factors, significant trends, root causes and actions taken to address them. This should include information on how patient safety improvements are being implemented across the Trust. And secondly, we want you to provide a written update to this committee within a period of 6 months that contains current levels of staffing, specific steps being taken by the Trust to ensure effective delivery of service, and information detailing steps being taken to ensure timely recruitment in key areas of specialist need, particularly LD and LDNA and dementia care, and report on the progress in meeting these targets in future quality reports. And finally, we want you to provide a written update that states the current levels of capacity of A&E, supplemented with regular updates to this Scrutiny Committee on meeting key performance indicators. And on Councillor Maxwell's point about patient feedback and continuous improvement, you mentioned about supplying some information around your mechanism. I think that would be good as well as a further recommendation, so we can understand how, what structures and mechanisms are in place for patient feedback and how that beds into continuous improvement of quality of patients in Northamptonshire. Thank you, and thank you, Julie, for answering those questions.
Thanks.
Moving on to the second item on the agenda, for Polly Grimmett to present the performance of Kettering General Hospital. Rebuild.
Yeah, thank you very much. Thanks, committee, for welcoming me back. Delighted to be back. Last time I was here, I had the pleasure of presenting more detailed updates around exactly what was in our new hospital programme and what had been in our plans. So I'm not going to re-rehearse that today, but just to confirm that the Kettering Trust Board remains totally committed to those plans as I described to you last time on behalf of our patients and on behalf of our staff. As per the report and as you mentioned at the beginning, Chair, our Chancellor announced a national review back in July into many things, one of which being the 40 new hospitals across the entirety of the NHS. That review has started. We are currently expecting that to conclude in autumn. So we await at the moment to find out what impact, if any, that has on the timeline of our scheme and indeed on the budget that we will be allocated for that. But we're certainly working with the national team on that and look forward to hearing the public outcome of that in autumn. In the meantime, we are being given total support to get on with some of our early enabling works that we need to do on the site to get us ready to start to build our new buildings. I mentioned a few of them in there. A multi-storey car park, I'm sure this committee will be pleased to note, is one of those. So we are getting supported to continue with our planning work on some of those. In particular, our main enabling scheme is on our energy centre. So that will address some of the high risk that the current site has on the level of energy and power it takes onto the site and how it distributes that across the site. We're reliant on some very old, aged, steam-based infrastructure. So that has been recognised by the national team. We are progressing and have been supported to continue that piece of work as an early enabling at £53 million. That will also absolutely is part of our commitment to deliver net zero carbon on the hospital site. So we welcome our progression on that to provide a carbon neutral site in future. So those schemes are progressing. I think, however, it is worth noting that originally when the 40 new hospital programmes were announced, the timeline for completing the schemes was 2030. I think I need to announce to this committee that Kettering, certainly not alone, in fact the vast majority of the schemes will not be complete by 2030. As I say, I can't give you a timeline for when we're expecting completion because that depends on the output of the national review as to when we can begin. But we are waiting that. In the meantime, we progress with some other really critical infrastructure work that we're pleased to be able to progress with that sit outside of that national new hospital programme. The first of which that I mentioned in the report is our community diagnostic centres. So our work to deliver a community diagnostic centre at Corby in the Willowbrook campus is progressing very well. That is due to be complete early March time in 2025, where we will start to welcome patients into that facility. That's going to, as set out in the report, really is set to improve the ability for patients, the ease of access to be able to get critical diagnostics and therefore early treatment and improved outcomes as a result of that in their care journey. And then finally, my final point before I open up probably is our reinforced autoclaved aerated concrete, otherwise known as RAC, at Kettering General that is in our maternity building known as our Rockingham Wing. So we continue at pace with addressing the safety aspects of that and have been given funding to do that, and we're working with the national team to complete that work. So by the end of 2024, we will have completed all of our what we call fail-safe. It's known as our emergency propping to make that structurally sound. All of the patients are out of harm, out of that first floor of Rockingham. We've been able to provide other alternative locations for those services, including Spinneyfields that my colleague David mentioned earlier. So that work is due to be complete in 2024. We are looking more medium and longer term at what we then plan to do with that building. That is related entirely on that new hospital programme. So the two pieces of work in terms of a longer term plan are tied together. So the national team are aware of that, and as I said earlier, we're working with them and looking forward to the results and the output of that autumn review so that we can then determine the timelines and the longer term plan for our maternity services and what buildings they're provided from in the future.
Thank you, Polly, for the report. Just want to ask a couple of questions, and I've got members wanting to come in. You mentioned both of these things, the age infrastructure and the reinforced auto-aerated concrete. So there is structural issues, as you've highlighted. If there is a delay in the remedial works, what is your contingency plan? And how will it affect patient safety, particularly for maternity services, and how do you prioritise them in this scenario?
Yes, so whilst the longer term plan for the building is reliant and tied into the new hospital programme, absolutely the immediate plan is not reliant on that. We have been given early funds to be able to complete that work. So we have already started that. That is due to complete in later on this year in 2024. So that will make safe that building from a structural perspective. It also provides a good medium-term solution for our maternity patients that will not be in that area.
So what my question is, what if it's delayed, so it's not done in 2024? I mean, do we have an absolute guarantee that it will be done by that time, by the end of this year?
Subject to usual estates work programme plans, we've got contingency built into that plan. We've got both from a financial perspective and from a timeline perspective. So we aren't anticipating currently any delays to that being completed.
Okay, thank you. And the risk mitigation strategies with regards to the age infrastructure. What happens if there's service disruptions whilst waiting for approval and the construction of the new energy centre? Is there risk mitigations essentially for that?
Absolutely, yes. So the Trust has been running a risk-based mitigation strategy for the last few years. We continue to do that, so that has board-level oversight onto what that is. We have as well, whilst we are waiting for approval of that full business case, the national team have given us early funds. We have that in writing, that is already within our gift. So we have already started the works around that.
Thank you, Polly. Councillor Maxwell.
I have 3 questions. So the first question is, what happens if you don't get this funding? You know, if the funding never materialises, they've decided that it's not going to materialise, what exactly happens to the hospital then?
It's a good question. So there is, of course, a risk that funding won't materialise. It's really important that Kettering Hospital has a plan. We have a plan. We know the state of our buildings, each of them, and that's why we have prioritised certain services and certain buildings to go into those. There are other things we are also working on. In terms of looking at what services don't need to be on an acute hospital site anymore. As medical advancements happen, we know that, for example, that's why we're building community diagnostic centres. We also know some day case services don't necessarily need to be on acute hospital sites. Some outpatient services don't need to. So we're continually working through plans. We aren't waiting for that. We are continually working through contingency plans, working with other health and care partners across the system to look at what else we could do to mitigate against that funding not coming through.
So the next question is, at the present moment, what I gather is that when you have a baby, you then walk across, or you pushed across the car park to the ward that you're allocated. How much longer is that going to go on for, particularly winter coming up?
Sorry, I did it wrong. That relates back to my previous answer, actually. Those two pieces tied together. So there are emergency fail-safe propping that will be completed by this winter, by the end of this year. Will allow our maternity, our postnatal and antenatal patients and their babies to move back into that building in a very safe way that has been risk mitigated and safe. So they will then not have to have that journey that you just talked about.
And that's guaranteed that they won't be walking across the car park?
Yes, that's entirely reliant on the work that we've already started and are managing.
So the next one is the car park, because last week a resident came up to me about the fact that they came in to see somebody who was seriously ill in hospital and just could not park the car. That is a major issue with Kettering General, not being able to park. So if you come in for A&E and you can't get a space, that is a problem. But coming to see somebody who's really seriously ill is, for them, a major problem. You're just going round and round, and it's not as if we've got another car park somewhere outside Kettering General where people can go and then probably walk in. So what exactly is going to happen about this car park?
Yeah, happy to answer that, and fully appreciate that. It's incredibly not just frustrating but also upsetting emotionally for patients and for visitors that are going to visit those patients, and you know, at really difficult times in people's lives, we are adding to that distress currently. So we have got some work going on. I mentioned earlier one of our key enabling works is a multi-storey car park, a new multi-storey car park that will be down at the bottom end of the site, but we're not going to wait for that. So we've already started working with, there's a lot of staff currently that park on our hospital site, but we do have off-site car parking arrangements for our staff that are currently getting underused. So we have just made an agreement for a further off-site car park. We are now going to be talking to all of our staff to make sure that they are using off-site car parks, and we are providing bus routes and other things to enable them to come onto the site safely, to prioritise the on-site car parking spaces for our patients and our visitors. So we are actively doing that piece of work now.
See, the thing is, when I look at, if you go, where you go for eyes, for instance, that road up there is just chocker. And if you're going for an eye test, or you're going into that particular section of the hospital, and you've got to have drops, you can't drive, you've got to be dropped off and then come along and be picked up again. That area there is sort of quite antiquated. It sort of hasn't moved forward at all, really. And I just think that aspects of the hospital, I mean, you know, I'm looking from the point of view of thinking about residents who come up to me and telling me what the issues are, and that they say, well, what happens if it doesn't happen? You know, I mean, it's because the population's got bigger in Northamptonshire, and the hospital hasn't got any bigger to accommodate them. So it's how you're going to move forward if you don't get the funding. That's my concern.
Yeah, so absolutely, and I will pick up in particular out of here about the eye area. I know exactly the area that you mean. I will explore that as a specific area, particularly around drop-off facilities in that area. In terms of the multi-storey car park, you're absolutely right, Councillor, to say that is part of our new hospital programme and is reliant on that piece of work. The intermediate work that I just spoke about in terms of moving more staff off into our off-site car parking arrangements is not reliant on that programme. We are doing that now, and we are doing that regardless. So that should start to ease the parking problems in a matter of weeks and months.
Thank you.
I'm going to say thank you for that, because I think it is a big worry, particularly with winter coming up, that people, you know, sort of like going around. But equally, from the staff point of view, I think it's quite frustrating for a member of staff coming to work in the hospital and finding that they can't park either. And the car park really is very antiquated. That's my view.
Thank you, Councillor Maxwell. David wants to come in. Thank you. Yeah, okay. Councillor Jackson.
Thank you. Councillor Maxwell jumped in about the car park because I was waiting to say very similar, because the one thing I haven't heard anybody mention, when the major construction starts, where on earth are they going to put all the equipment, machinery, plus obviously the contractors' cars, because they will be coming in with vehicles? I would have thought the car park improvements has got to go ahead, regardless of a possible delay in a hospital. The one thing KGH hasn't got is adequate parking now, and to carry out a major improvement to that hospital without an additional car park will be almost impossible.
Thank you very much. I think I've answered a fair amount of that. I'll just pick up those other couple of bits. So the multi-storey car park that I mentioned, is an enabling scheme, so that will be in place before we start the major construction works, particularly to address the point you raised. We have already started some construction. I mentioned the energy centre and other things on site. We have already got agreements with our construction partners that they park off-site. They aren't taking up car parking space on the site. And then the rest of the answer, hopefully I've already done in terms of the temporary facilities.
Is that okay, Councillor Jackson? Any follow-up?
The one thing that this will cause, if you have construction workers parking all their equipment off-site, that will push up the price considerably. So obviously a price is one of the deciding factors whether it goes ahead. And if you suddenly say to a contractor, you have to provide all off parking for the bulk of your materials, the bulk of your plant, then I'm afraid the quote will be astronomical.
Thank you. Councillor Jackson, Councillor Lorman.
Thank you. Well, it won't surprise you that the other thing that I get thing was parking, so I won't repeat. But I just want to just inform the panel really that the hospital has a travel plan group, and officers from this council, both in the planning and in the travel areas, sit on that. And have had input and have listened to what the issues are. So, and I know that's gone backwards and forth. And of course, we've recently improved our bus service improvement plan, and some of the things on there were enhancements to bus services. Because I mean, if you want to go from Wellingborough to the hospital up now, you have to take 3 buses. And that's not helping. So, some of the new suggestions for routes will cure that. The other thing, it would be a help if and I'll declare an interest as the Director of Shire, if the hospital would promote the medical car service a bit more. That would alleviate the problem, because medical car service can come and go and won't take up the parking spaces because they've got their own dedicated ones, but they'll be able to come and go, and that will help as well. And the hospital could promote that a bit more, I think, and that would help. Just actually on the point just now, I'll hark back to when we built the prison in Wellingborough, and we had a compound that was 2 or 3 miles away on an industrial estate that the council owned, and all the contractors' vehicles were parked on that, and they ran a bus service between the prison and this site. So it can be done quite easily, and they were all quite happy with it.
Thank you, Councillor, for those 2 things. I'll take those away. Thank you very much.
Thank you, Polly. Councillor King.
Thank you. My question is about the RAC. Is there any other parts of the estate that are affected by RAC? And if not, are there any parts of the estate that will go beyond their lifespan by 2030? I say that because the Prime Minister did say that hospitals with RAC would be prioritised.
Thank you. So I can assure this committee that we have done a thorough survey of every single building, both ceilings, walls, everywhere within those buildings, across the hospital site, and indeed on our off-site locations where we also provide services, and that is the only part of our estate that has RAC, to conclude on that. And once we have concluded the emergency propping, we are told by our independent surveyors that gives the building a lifespan of at least 10 years in terms of from a safety perspective. In terms of other buildings on the site, I think it's clear to anybody that uses the site that there are many buildings that are beyond the life cycle that we would want to be treating patients in. Councillor mentioned the eye department. That's in one of the areas of the state that is of the oldest, and that is absolutely our priority, to replace those areas of the estate and make sure that the services that are currently provided out of there get new homes. So that we can make sure that our staff are working in modern facilities and our patients get treated in modern facilities.
Thank you. David wants to come in.
Thank you, Chair. So a couple of points. Correct me if I'm wrong, Polly, but you mentioned earlier on the Community Diagnostic Centre. So one of the aims of that is to reduce people going to the hospital site. So there are other pieces of work that aim to reduce people needing to travel into the KG8 site. We also have the One Public Estate Board, And there's some real opportunities to talk about the shared assets that we've got and how we can potentially enable some of that to work better for you. So, for example, we have a depot just up the road from where you are. At the moment, we have bin lorries and we have my housing teams that work out of there. But it's possibly about how we look at some of that space and can it be used differently to support enabling something which is hugely important to our residents moving forward. So let's not rule out that we could use our One Public Estate Board to explore some of the wider solutions in that sense. And then there was just one question which I probably know the answer to, but I'll ask it anyway. Have you had shared with you from the national team that are undertaking the reset review what methodology they will use to prioritise the 40 schemes against each other? So it won't just be done on a cost, surely it must be done on risk, it must be done on things like access. So have you had any insight into how they will apply that and compare apples with apples in that sense?
So on your first point about the One Public Estate, OP absolutely fully support us working together across the system through the public sector on how we can use our estate better regardless of organisational boundaries, fully in support of that. There is a terms of reference for the national review, as I understand it, that have been written. That has not been shared with any providers of the 40 hospitals, so we have not seen that. I have my own assumptions and views as to what I think they will be using, and you mentioned some of them there, David. There are probably others as well, and my councillor over there mentioned some of the other RAC hospitals. But I would be incorrect if I was to guess at what those are, because we simply haven't been told.
Thank you. Councillor Maxwell.
You mentioned about using car share or types of transport which would get you to the hospital, but it's the cost. So the costs are coming from where I live to the hospital. A round trip is £45 round trip. That is a lot of money for pensioners or people with a disability. And I think that whilst you were saying about the bus service improving at the moment, to get to the hospital by bus, there's no joined up thinking. So you, from where I live again, you have to get 2 buses to get to the hospital. But then coming out of your appointment, obviously you've got to go back, but you're standing at the bus stop waiting a long time to get back. The car, where you get a car, is good, but it's the cost. It's just, it's outpriced itself. You know, people, feel that, and again, from the eye point of view, you've got no choice. You can't drive there and drive back again, which is what you'd like to do. You've got to get some sort of transport to get there. So, whilst it's an excellent idea, I would like to see how we're actually going to get round helping people who've got to pay for it.
Yeah, thank you. And Councillor Laura mentioned about our travel and transport group, and that's exactly the kind of things that they do look at. Wherever possible, we are trying our best to make sure, I've mentioned earlier, that people don't need to come onto the acute hospital site if they don't need to. Community diagnostic centres is one example. We've also been exploring what services we could move into town centre locations. That's generally, we explored that some time ago, and David and I have agreed that we need to reopen that conversation. There are certain services that elsewhere are provided in the middle of town centres, high volume, so that they're more accessible by more people in terms of a public transport route, because most public transport routes go into the town centre, so it's a lot easier than having to catch a bus back out again to the hospital. So that's another thing that we're trying to explore as much as we can.
Thank you. Councillor Lorman.
Yeah, very briefly. If you're on certain benefits, housing benefits, and you can claim the travel costs to the hospital for appointments, and that includes medical car, which would be about half the price you just quoted. So there are things people can do, which is why I say it could be better publicised.
I am going to bring this item to a close, but John Paul Carr, Councillor. Thank you.
Having spent the last 10 weeks backwards and forwards to the hospital with my father and experienced the car parking facilities, I can understand the frustrations of everybody, particularly when your father's disabled as well and can't really walk more than about 20 metres at times. I would have thought the simplest solution for all of this is a discussion, obviously, with the group that you talked about to do with transport. I can't understand why a site like that can't have, what's the word I'm trying to think of? A park and ride scheme. It's such a nightmare, even once you get onto the site from a safety point of view, driving your car around. There doesn't need to be cars on that site at all, which would help immensely. I'm sure once you do some number crunching in regards to, as Councillor Jackson said, about there being a site, either whether it's on-site or off-site for construction workers, to providing some kind of off-site park and ride scheme, possibly might be more cost efficient. But you're the expert, I'm certainly not, so I shall leave it with you to have a think about it.
Any response to that?
No, thank you. It is absolutely on our agenda, and our park and ride is what we provide for our staff. We have certainly started to explore what that might look like for our patients who are able-bodied enough to be able to access that.
Thank you, Polly. And the committee's only recommendation for this item is just to come back at the earliest opportunity with a full report and detail around the rebuild programme once you have more information after the review. Thank you. Okay, on to the next item on the agenda. It's Eileen Doyle, the Chief Executive of the ICB for the Wellbeing and Mental Health Services for Children and Young People in Northamptonshire. Thank you.
Thank you. Thank you, everybody, for the invitation to come along this evening. I've come with three other colleagues. Myself, I'm Eileen Doyle, and I'm the Chief Operating Officer for the ICB. I'm here with Ellie, who has done lots of work around this and is part of the transformation team that work in this area, also from the ICB, and two colleagues from NHFT, who are main providers of the service. And David is going to take us through most of the slides, but just really by way of introduction, children and adolescent mental health services are not just health. This is probably the one area that, if I had to point to, multifactorial working, lots of agencies, voluntary sector, Children's Trust, local authorities, this is probably the one area that we really knit together in terms of the offer, because it's not just about children and adolescents who come into the CAM service, for example. There's a lot more around prevention and intercepting and having children grow up well and understanding when they need further support and getting into difficulties, that we're there at an early stage. So it's really by a way of introduction. This is not a medicalised model of service. This is all sorts of people, and we'll go through the presentation. You'll see the vast range of services that are on offer in this county. Suffice to say, there is always more we will strive to do, because as you will know, we hear it all over the media, the numbers of children and young people who want to come in and need these services from an early start, particularly post-COVID, for example, has grown, and so therefore we need to keep pace with that. But that's notwithstanding the work that we want to tell you about that we've been doing tonight, but also recognising there will always be more that we can do. So I'm going to hand over now to David, who's going to talk you through some of the services that are on offer and some of the progress that we've been making, and also some of the areas where we know we've got further work to do. Thank you.
Lovely, thank you, Eileen. So yes, I'm David Williams, Group Director of Strategy and Partnerships at Northamptonshire Healthcare Foundation Trust. So if we can go on to the next slide, that would be brilliant. So just wanted to explain the service offer and the way that it works. So the columns and the different colours, I think, are really important to have a look at. So we use the Thrive model, which is a national model for support for children and young people. The green is about how do people get advice. So that's the prevention, self-help, understanding ways of working. The blue is about getting help. So a range of early help services that can provide a little bit more support and ways of working things through. If people still need more help, then there's the purple, getting more help. And then there's the orange for getting risk support. So the most acute, the most high-intensity services are in the orange. The advice, guidance, self-learning and things are in the green. So that's how the process works. And then the rows that you've got illustrating the services are different organisations, different collaboratives. And reinforcing Eileen's point in the introduction, the services aren't all commissioned by the NHS. Some of the services for children and young people will be services that you'll do, you'll support, they'll come up through public health, but there'll also be things that engage with schools and ways of working. So we've got about 44 different services that are those little horizontal bars on there with the ways of working. As we come into the detail about service performance and ways of working, we're going to focus on one of those bars, which is the very top purple bar for today, about CAMS community support, and just work that through. So that's a range of the offer and the partnership working we're doing. If we could go on to the next slide, please. One of the key things then is how do you access support and how do you take that forward? So people can access the support just by we've got one different slide, but that's fine. I'll come back to. Can I go up one slide for a moment and then I'll come up the other way? Brilliant. One of the bits we wanted to talk about was about referral pathways. How do you refer in if you need help for a service and a way of working? So for some services, you don't need to refer. You can just go along and attend. So things like an iDiscovery programme is a series of workshops. You can just come along and attend. You can learn new skills about how do you work things through. We've got wellbeing cafes that you can go to find support wherever you want. There are locations that include Corby, Kettering, Wellingborough, Rushton, Thrapston, I think are the ones in the north of the county. They're open different hours, different weeks, and people can go along. Individuals can self-refer into services, so you can refer into Happy Heads, counselling, Restart, emotion coaching. People have got access to live chat, 9 a.m. to 9 p.m. Weekdays. Can text the school nurse for a conversation, so remember that many people might not want to phone, might find it difficult to phone, and actually having a text-based conversation, a live chat conversation is a really good way of people exploring stuff. There is a phone number there as well, which again is 9 till 9, for parents, carers, as well as young people for seeking advice and supporting stuff through. So there's a whole range of different services that are there. If we go on to that next slide then, please. It takes us into waiting times and where we're looking at. And I think the important bit about thinking about waiting times is think about the impact that different services and the services we invest in those different tiers has on each other tier. So if we didn't invest in anything around getting advice, then undoubtedly the waiting times for having help would be longer. And it's that kind of balance every time of trying to make sure we get the right level of resources invested there. So you've got the green line on the graph there, which is our average waiting times for our services with inside getting help, getting advice and support. And we've actually been putting in extra support for Happy Heads and other services and ways of working to help bring that one down. Our wellbeing cafes are seeing 100 to 200 people a month to have some support. In terms of the blue line and thinking about things and working stuff through, the getting help bit there is all about how do we help people early doors. Mental health support teams in schools. We've got new teams coming into Kettering schools starting this term and working things through. And we've now got 30% of schools that have got mental health support teams in there supporting young people and working things through. Counselling. Reach Collaborative is a collaborative of voluntary and community organisations across the county, and they do absolutely sterling work on supporting things there. As we come into the purple tier, we've got a larger number of our services there, and we're doing everything we can, and you can see in the graph there how we've been bringing down those services. So that now that the number of pathways where people are seen within 18 weeks is over 90% of what we're doing. And we've really worked hard at reducing the waiting list, and we've managed to reduce that by 63% since April of 2022, bringing it down to January. And then you can see the very, very, very short, if occasionally zero, waiting time for our really acute need patients. And in Northamptonshire, about 4 years ago, we decided to take on the responsibility of being what's called a lead provider across the East Midlands for the CAMS inpatient support. So that's for children and young people whose mental health needs an inpatient stay. And we've been working across the East Midlands with that. We now have the lowest waiting list that we've had for 4 years there. And we're seeing people really quite quickly for services. We've been able to really speed that up. So I hope that gives a good understanding of the different elements of Thrive and the waiting time. what we've done on the next slide, if we could go forward to it, is just to pick up and just have a look at the CAMS community pathways, so that purple bar that was at the top of the Thrive model at the beginning. So the pathway there just shows a process going through, starting at the top with an initial assessment, our core pathway of how do we support people onto our pathway list, how we go through the clinical review and the ways of working through the types of sessions. But I thought it was just worth reinforcing that it's quite simple to think about it just being one thing, but actually it's all about getting young people and their families the support they need. So there are lots of different pathways. So it might be about individuals having really strong emotions and needing help to support with that. It might be about mood and anxiety, and then there's a separate pathway for that. It could be about a trauma pathway, dealing with something that's previously happened that's been traumatic and managing that through. Neurodevelopmental pathways are really important and a growing area of supporting people. Relationships becomes really important, both within people of their same age and adults, and support there. And then also we've got things like various different groups supporting people with tics or Tourette's or ways of working. So that kind of different way of breaking down the pathways, I think is really important to get people the right help and the right things they need. So the last couple of slides that I've got then were just to have a look at what we're doing around waiting times and where we're going. So the red arrows are just identifying areas where people are starting to wait longer or the numbers of people are going up. But the green arrows are also where people are now waiting less and getting their treatment. So you can see there are more green than red. We keep constantly making changes and working things through. And we keep sitting there and saying, is there anything we can do differently? I'll show you in a moment, but some of the things we've done differently are to invest in community youth groups, prevention works and other ways of trying to get people early support so that their acuity doesn't continue. Another thing that we did as we go to the next slide is to have a really good look at the clinical risk reviews and to make sure that if anybody's waiting, that we spend time to look at any harm, any identification, have we got it right, does people need to come forward? And so that triage process is really important about making sure that we've got the right people getting the right help as fast as we can do for them. So I just wanted to reinforce there's a clinical assessment while people are waiting to get people the right care and the treatment. So the last two slides, the last slide from me. So thinking about what we do differently, thinking about the partnership work that we can do and the ways we're working. Here are some examples of some of the things. And I think it's important to say that we're very committed to delivering NHS care and supporting people wherever we can, but we can also do an awful lot to help families and young people by connecting with other organisations outside of the NHS. The NHS doesn't always become the first place that everybody wants to go to get help or feel they need. So work like Northampton Saints provides a way to have a conversation with people that doesn't make it feel like it's an NHS conversation. Makes people more willing or able to be able to access it. So if they can help us support stuff, that's good. Mental health champions to help really promote good mental health and well-being in our acute trusts to help drive it forwards good. I've touched on the mental health support teams in schools. Emotional coaching, happier families, really important work to bring people together, voluntary and community groups. Online digital front door, an online way of accessing help. We're probably all a little bit too old, but maybe some of us are still glued to our phones quite a lot. But getting help that way is quite a good way of working things through. Wellbeing cafes, additional supports for our LGBTQ plus young people who need additional support facing inequalities. I touched on Happy Heads earlier and I Discover. So hopefully that gives a range of different flavours. Just going to hand back to Eileen now for a brief sum.
Thanks, David. So I think that what we've hopefully demonstrated to you is there's a really strong partnership ethic to this area of work for children and young people. And as I mentioned, it spans across all of us. So local authorities, voluntary sector, children's schools, everybody's got a really key role because this is not just about getting to the end, you escalate and then you get into services that actually arguably we could have prevented earlier on in a young person's pathway. And I think that, if we were looking at a blueprint, and Ellie and I work in commissioning, if we were looking at a blueprint, if other services took this approach, so some adult services, whatever that might be, I think we would come a long way. So I do think this is the blueprint of how we should all be working and trying to roll that through, because it's almost boundaryless in terms of when I sit in rooms and I listen to people talking about these services, it's really difficult to tell where anybody is from, because actually the most important focus is around that young person and what we can do for them. Obviously, there are lots of commission services, but as I say, it's as much about the emotional well-being of those young people and their families, and trying to intervene at an early stage before, for some young people and children, they will end up in the more acute end of things because that just happens to be their condition. But if there is any way of supporting, and also supporting them when they do have those acute episodes, to de-escalate and come back out into what we would all describe more normal lives. As I said at the very beginning, David's very articulately said we have made improvements, and that's great, but we do know that any wait is a wait too long. But these are highly, highly specialised services in some of these areas, and it's really difficult sometimes to make sure that we can grow them in the way that we would like to. It's not just about a financial thing, it's about having the experts out there. So the more people, a bit like Julie said earlier, the more people within our services that we can train and help and support to understand the needs of children, young people and their families and friends, the wider our reach will become. And so we think actually that this, certainly for Northamptonshire, I think we've made great strides even in my short time in this county, and we are all very committed, irrespective of the difficult backdrops we're all working towards in terms of growing waiting lists and financial difficulties, that we're very committed to this area of work, and hope that we've been able to demonstrate that we are all in it together, and hopefully you're seeing those rewards now. Thank you.
Thank you. I think it's a very comprehensive report and fantastic presentation. You've answered a lot of the questions that I had, and I raised a few at the Chair's briefing, namely around access. I think you've covered that quite well. There's multiple routes of access. And I believe you've also touched on what happens to those children that are on the waiting list as well, because that was another concern of mine. I'll ask you this question: what are the projected trends for the service demand, and how do current resources align with these projections?
I think we're likely to see children and young people's demand increasing. Given everything that's going on, that'll absolutely happen. In terms of how do we align resources, I think we're constantly sitting there and working, how can we do some different things, how can we improve? There is a children's pathway bringing together lots of different organisations, actually chaired by Northants, with the option of saying, how do we transform services for children, how do we come together? So the use of resources question, we keep sitting down and going, what are the options to do more on the Thrive model? How can we shift stuff more towards the green? How can we take things forward? So that's the kind of question we keep asking ourselves, is what else could we do?
Yeah. Thank you. Thank you for that. Again, you've answered another one of my questions already around the Thrive model, and I think that the way that you articulated it tailors it specifically to Northamptonshire younger population, so I won't ask you that question again. What steps are being taken to raise awareness among children, young people and families about the availability of these services within the Thrive model?
I think one of the slides referenced iDiscover as a digital means of making sure that there's the availability of services is clearly available at all times of the day, etc. One of the other slides also referenced the additional funding to try and develop a better single front door for these services. We've been very lucky in Northamptonshire in what we've managed to develop, but it can, once you look at the abundance of services, be quite an intimidating picture for some people when trying to find out which service is for me. So that latest development is also intended to include the ability digitally to be able to navigate yourself using a clinically ratified digital approach to see which one actually would fit me best as part of its promotion for both carers, families and also other professionals. So both a publication of services and what's available, also the ability to navigate what could be confusing for people. So that's that intent.
Yeah, thank you. What's this digital pathway called? What's the?
It hasn't got a name.
It's not
yet.
been developed yet.
No, but whatever we do, we will do our utmost to link it with the Family Hub's digital front door and make sure that there's not another front door.
Thank you for that. Okay, Councillor Keane for the CAMS.
Yeah, thank you. What additional resources have been provided to CAMS to ensure ongoing reductions in waiting times? I want to tailor that. I know the pandemic had a huge impact on our young people, and are you seeing an effect of that coming into your waiting times?
So when we say CAMS in general, we have seen an increase in the young people across the board through all of the Thrive levels. CAMS is just one service within those pathways. And I think we're spending additional funding and we're really delivering additional resource in the getting advice and getting help level to try and prevent young people from escalating into CAMS, ultimately, because we don't want our future generations to be doing that. In terms of CAMS itself, we have been working over the past couple of years, and that pathway map that you saw today is kind of not a new approach, but a developed approach, I would say, over the past couple of years in terms of the way the workforce are aligned within CAMS and the way young people kind of will navigate through those pathways depending on their need. So hopefully that means the real specialist pathways that are in the purple on the diagram, young people, only about 15% of young people coming into CAMS end up on those pathways. So the primary workforce within CAMS is on that core pathway to support all the referrals coming in, and we've got the workforce there because that's where the bulk of the referrals are. And then we have obviously specialist workforce within those pathways to cater for a smaller cohort, because that's what we see in terms of the referrals.
Do you want to ask the further questions? Have they been answered?
Yeah, how does the integration of CAMS services within the Thrive model specifically address early intervention for young people at risk? And what's the success rate of the CAMS intervention in terms of improving mental health outcomes for children and young people? And what is your biggest driving factor between child and adolescent mental health issues?
Right. So in terms of how does it integrate into the Thrive model, I think what we've all done by bringing the Thrive concept together is to be able to give everybody who provides different services a shared understanding of their role in looking after people. Before, it might be a service that sat over there, a service that sat over there, another one that sat over there, and they may or may not talk together. By bringing the Thrive model together, we've sat down with all the different providers and said, actually, your part is the getting help bit, and then said, when it's time to refer somebody on to the next bit, this is how you do it. So it's that the connection bit for CAMS has been about connecting all the different services up. CAMS knowing what might have happened before and who those contacts are, and services knowing who to refer people on. So that's kind of the beauty of the Thrive model, for connecting people together and everybody understanding their role. For outcomes and updates on the second and third part.
Apologies, I was just looking up an acronym, which I don't know, which I really should. So one of the main tools used for judging outcomes within CAMS itself is something called a CGAS, which is the Children's Global Assessment Scale. Didn't remember that. So that usually sees a result of between 88 and 90-something% improvement. So the children that are seen either see maintained or improved at that level, 88 to 90-something% of children. So the interventions are effective, which makes it frustrating sometimes when they have to wait for them.
Thank you. On to Councillor Jackson for waiting times. Thank you. If you can put your... sorry, Councillor Jackson. Can you put your mic on? There we go.
Terribly sorry. I'll start again. What specific measures have led to the reduction in waiting time since October 23, and how do you plan to sustain further improve these reductions? And also, are the number of children requiring mental health services in Northamptonshire average for the population? Thank you.
So some of the things in terms of sort of helping people wait less time. Clinical risk reviews have been an important part of the triage to make sure that people who are needing help get the right help. We get them into the right pathway straight away. So that's been a really key part of working things through and looking at things. In terms of demand, we do think we are a average county in terms of demand, as in there isn't anything that's higher or lower about young people's needs for mental health resilience, support and emotion in Northamptonshire than anywhere else. So we're then trying to provide the support. The other aspect which I'll reinforce through today's presentation is the more we can do to help people get early help, the less it helps people, the more it means that people don't wait. Because if we can help people build their own resilience, if we can help communities, schools support each other, then that helps us reduce the waiting times elsewhere.
Thank you.
Thank you, Councillor Jackson. Councillor Maxwell.
How are partnerships between the NHS, local schools and community organisations fostered early intervention and preventing escalation of mental health issues? That's the first question. So how are you actually working together?
So we've got system regular formal meeting that comes together, which is the one I touched on, led by Northants. So that's a way of bringing together community organisations, the NHS and everybody focused on a plan. So there's like a formal process and a governance process. What I'd say is there's an awful lot of informal things. So a chance to build networks and find ways of working things through. To try and give you an example, I was working with in Reach's offices with Reach last week or the week before. I think Dan's been in working with Reach at least once a week recently, and multiple other conversations. So there's a formal governance structure about helping us, which is sort of coordinated by the ICB but led by Northants. And then there's a whole host of informal things of people coming together and going, right, how do we solve these problems? How do we work together?
And just to add to that, I think back to my blueprint statement, there's a real drive, enthusiasm and focus on this area of all those people that are involved. And so whereas we don't perhaps see this in other areas of health, that informal relationship that David's just talked about, that's day to day. It's not, I'll pop in, I might pop into one of David's offices in 3 weeks' time because I'm going to make a diary entry to make sure I get there. All the people that are involved in these services just work together, and it's back to it's difficult to tell who's who in the room sometimes because everybody is just focused on the delivery, and so therefore I think it's that approach does really reap benefits, and it really improves those relationships so that it's easier to just pick up the phone, or you have that conversation ahead of anybody, ahead of any part of the service that is either something we haven't spotted or something we should have done differently. You know that it's iterative, and it's every single day that people work like it together. So I genuinely think it's inspiring, actually.
So my next question is that given those two ends of this, if you're looking at children in reception year 1 who need help, what some people are finding is they're not necessarily getting the help that they need because it's not being picked up. You know, either the parents aren't actually getting help from GPs, or GPs aren't flagging it up, or getting an appointment with a GP is quite interesting. But I think that, so there's that aspect to it. And then on the other end of the spectrum, so if you're looking at years 10 and 11 who are reluctant to get help, you know, they feel embarrassed about getting help, they won't necessarily go to somebody within the school to get the help, and they feel embarrassed about referring it to their parents. How do you actually target these children?
Yep. So thank you. Some really useful points in there. The bits about helping people get help. I'd say we do, from an NHS perspective, have a range of services. So health visitors, school nurses will be there reading services. But what I'd also say is the bit that we want to do and the strength of a partnership is how does everybody help families? How do community and voluntary organisations help families? What's your role as the local authority? What can you champion? Because coming and bringing those common messages together makes a really, really big difference. So from an NHS perspective, community and family resilience is really important. If people have got purposeful activity, they've got employment, they've got good housing to live in, they can afford to do what they want to do, actually their mental health is an awful lot better. So all of those sorts of things start to come together. In terms of embarrassed to ask for help, that's part of the reason that we want to work in partnership with organisations that don't just have the NHS logo above it. So we do deliver services, and NHFT, we deliver services across over 100 different locations in Northamptonshire. And many of those are community venues and other places, but then you've also got community providers. So it gives people an option to go to places that don't have a big NHS logo on it. The other key thing, of course, is that you can phone, text, or have a live chat with us. So you can ask a silly, if we take the year 10, 11 challenge, you can ask a question on the school bus in the way in to school in the morning. You just look like you're texting on the phone, just like anybody else is currently texting on their phone. So those types of things reduce the embarrassment, and we hope improve uptake and support to people.
Thank you. You want to follow up?
Another question. So I actually was dealing with a resident recently, which some people are quite surprised actually that we tend to get targeted or asked questions about it, and getting hold of help at that. It was a Sunday actually. Getting help for that person was quite difficult actually, and I think if we as councillors were aware of where they can actually get help, that would actually help us. I don't think we know enough information to do it.
I was going to say we have added an additional slide to the pack after the Chair's briefing, Councillor Law, but I don't think we quite managed to communicate and get it up to date, so we'll get that round to you. And I've linked the websites of our providers, particularly where the service is a self-referral or no referral, so you'll be able to share that. I think another key thing we're doing in that area is the front door that Dan mentioned earlier. And the idea is that once we've got that developed, our young people and their families can use that to find the right services for them. But yourselves, community champions, a scout leader, a GP, anybody would be able to use that to navigate our services and understand which service is best placed to support a young person. And a lot of those services will be self-referral, and some of them would have no wait. I think the other part is, in terms of communities accessing our services, going back to the point you made about potentially feeling embarrassed or kind of the stigma around accessing that, we've got things like the LGBTQ plus groups in place because we know that within communities that experience health inequalities, they often find barriers to accessing services. So groups like that, while they're not necessarily designed with a mental health input, they bring the trust of our young people with our providers. And once we build that trust with our providers, we often see that young people then feel more able to access our services. So it's all kind of part of that holistic package of care that the Thrive Levels help us to generate.
Thank you.
Thank you. On to the next point, monitoring and performance. Councillor Lawman.
Thank you. But before I go on to those, I perhaps wanted to build on something that one of my big things is prevention. And I'm not sure how you prevent in this area. Catch early, yes, I can see that, but I don't know how you. And I wanted to ask perhaps a bit more on how you work in partnership with schools, and particularly get information out, because as far as I can see, and I'm a governor of several schools, a lot of them don't have nurses these days, and they have obviously safeguarding officers and various other things, but a lot of them don't have nurses. So I would appreciate a bit more information how you work with schools, how you can get into to the, if you like, the minds of the children to make sure that you get early prevention measures.
Lovely, thank you. I'll pick up a couple of bits, and then if I'm anything extra, please add in. So I think in terms of how do you do prevention, I think the key bit that we're really wanting to focus on is how do you build a young person but also a family's resilient skills, their coping skills, their understanding. And it's really important that we help people understand that some days there are bad days and some days there are good days. How do you manage with those bad days? And the support actually that comes from communities in the very broad sense, it doesn't just come from the NHS. So that message of how do you build resilience in the community services when you're having a bad day, is there somewhere you can go, is there someone you can talk to? That's the big prevention bit. And you can do that with schools. So we do have school nurses assigned to every school around every state school operating in the patch, and they will provide support. They will have a healthcare plan for the school. They will be involved, and they will, depending on the need of the individual young people, carry a certain element of a caseload for those who need a little bit more support. And then mental health support in schools is helping to provide both skills to upskill teachers, but also to help support people in school. So there's a whole range of prevention bits there, which does fit into, how do we do schools and prevention.
So are those your nurses that you assign? You said assigned to schools.
Yeah. So there is
not school nurses as
so they are school nurses who are contracted. They have specific school nursing skills as opposed to other specific nursing skills, and they are working with the schools across Northamptonshire to develop both healthy living, think about vaccination plans as well. We're not in the days where each school would have its own matron, as it were, but those sorts of things.
Your colleague mentioned I think it was C-gas earlier, which is seemed to be a talk. So is that where you get the metrics or the KPIs to assess the overall effectiveness of your services? And is that where you can get the information to review the long-term outcomes for young people who have accessed the services? Is that your, or is there another way?
It's one of a range, so different organisations tend to use different clinical outcome scoring tools, but they're all of a really similar principle, as in you measure the effective well-being of a child at the beginning of their journey, and you measure it throughout the journey, and you measure it at the end. And really, the measurement of a clinical outcome is there actually an improvement at the end compared to what it was at the start? That's one of a range of many, many reported measures across all of these different services, which contribute to a picture of effectiveness. It tends to be based upon a performance framework that covers management of resources, outcomes, patient experience, and also safety. Put those things together, and that tends to represent an effective service.
Any follow-up? Well, not quite a follow-up, but another couple of points if I can. In the report, you've mentioned these wellbeing cafes, a number of them, about half a dozen of them, and getting a considerable number, three-figure number of children. I'd not been aware of them, so I just wondered if you where it actually was, particularly I'm a Wellingborough councillor, so particularly the Wellingborough one, and how do young people find it? How do they know where it is, and how do they find it? And obviously, you said they can self-refer, so that's fine. But how do they find it? And the other thing, what your colleague talked about having in future, I'll call it a single point of entry. We've recently had presentation from Support Northamptonshire who are doing exactly the same thing in a slightly different field, but I wonder if there might be some learning and some collaboration between the two to enhance that entry point.
Lovely, thank you. In terms of Wellingborough, it's Service 6 who provide the Wellbeing Cafe, and it's there Saturdays 10 till 2. We put quite a lot of feedback out on social media. Our school nurses will share it. Service 6 do and work it through. So it's a drop-in place that, and actually quite often young people and their families will come in and just want to sit down and talk to people. And it's a mixture of Service 6 led with the opportunity to call through to one of our nurses for any specific issues and ways of working. But yeah, and on your second point, we're always happy to explore other learning and see what we can learn and develop from others.
Thank you. We're going to begin to wrap this up. David wants to come in. I haven't forgotten about you.
Thank you, Chair. So I'm going to ask a couple of questions, but I'm probably posing them at myself as well a little bit, but it's probably helpful to do that. First one, on your slide set when you were talking about waiting times for young people, and we keep talking about how do we move things more to the green. The longest waiting time, the average waiting time that we've got is 15 weeks for getting advice. So how do we turn that round in that sense? I think the other bit which certainly I know Dan's posed back as a challenge to me as the chair of Children and Young People's Partnership Board is how do we get a bit of visibility around the expenditure that's happening in this area? Because whilst this looks like a lot of services, what's the value of money which we as public bodies are putting into those? And how many people are they supporting in that sense? Because what I don't get from our green line that says the average waiting time for information is 15 weeks, well, how many people at any one time are waiting on average 15 weeks to get advice? Because advice needs to come quickly, not take the longest out of all of those interventions. That's the first element. I want to say thanks to Dan for mentioning the family hubs. But what I would say for councillors, and I'm probably going to get a tattoo of the QR code, please sign up for the Family Hubs app. There is huge amounts of information. It pulls information from NHS websites as well. If you don't know about something and you want to try and find out locally what is happening in Northamptonshire, that app will lead you through it. You can receive notifications about the subject areas that you're interested in. It's not just written information, there's videos, there's lots of information in there. So please do explore that. And I know when we were at the digital front door launch, I put that challenge back in about don't develop your own. Let's work together on that. So it's really important that we do that. The final bit on that Thrive model, I really like that map. But what it doesn't necessarily say is, well, if I was to invest more in this intervention over here, it would have an impact on this over here. And what you'd be trying to do is reduce the amount of money that you have to spend on those orange and purple things by investing in the green and blue things. And is there a way that we can start trying to map those interactions and what the right value would be to move from one into the other? And I'm posing that to myself because a number of these services are mine as well. But quite often we just look within our own organisations and we're not thinking about, in a certain respect, we're saying we're turkeys voting for Christmas because it might mean, well, we're looking to reduce a service that NHFT provides because we want to resolve people's challenge earlier on, but that means taking money out of that area to spend it in another area in that sense. So I know you won't have answers fully to those because we have these discussions fairly regularly, but I think that visibility of expenditure, because when you look at the expenditure that we spend on children and young people in comparison to the vast expenditure that we spend on adults, but actually investing in the health and well-being of our children will hopefully lead to them being healthy and well adults in that sense, is really stark, the difference between that.
There's some good questions. Answer what you can, please.
Sure, I'll start off. In terms of the bit you mentioned about waiting times for getting advice, the reason that the data shows like that, and it is, I have just put it on the slide just under the graph, is that the data for that only includes the Happy Head service. So within the Getting Advice service offer on the Thrive framework, you'll see loads of other services, but they have no wait lists because they're open access. So things like the Wellbeing Cafes, there's no wait list, you just turn up. Things like iDiscover is available all the time, so they're not captured within that data. And that's why that wait essentially looks high, but actually there's a load of other services on offer for immediate support. And in terms of that specific wait list for Happy Heads, which is high, the ICB have massively increased the funding for that in 2024-25. We expect that service to triple if not nearly quadruple by the end of the financial year. And we've implemented a staged approach within that service, so it kind of works across multiple tiers to support young people as well. So hopefully by the end of the year we would see a massive reduction in that, but the other services are there and available at all points. In terms of kind of left shift on the Thrive diagram in terms of funding and demand and trying to catch young people earlier and prevent escalation, something that we've done within the mental health workstream in the transformation programme is map our funding, our workforce and our demand by Thrive level. So we can say we spend X on getting advice, we have this many referrals and this many workforce, and we can do that for all 4 levels. We've done that for 23-24 and we've also done that for 2024-25. So we should slowly over time see ourselves shift towards a more preventative model, and that's the way that we'll be able to track that. And because we've got referrals in captured on that as well, hopefully we'll see the referrals decrease in the higher levels as well. The other thing is the expenditure on children and young people's mental health and emotional wellbeing is detailed in the local transformation plan, which is published every year for children and young people. And the 2025-26 plan is due for writing any time, will be published this side of Christmas. And that expenditure will be in there for 24-25 and plans into 25-26 as well.
Thank you. And David raised a good point about working with us around the digital front door, which I'll be keen to know more about once it's developed. Any further questions from members? Councillor Maxwell. Quickly, please.
Roughly, how long is the waiting time for a child, at school, to see somebody? Roughly, you have referrals, but is the waiting time a long time, or is it quite quick?
It will completely depend on what that young person needs. It could be as short as going straight down to one of the Express Yourself cafes that night. It could be self-referring straight into a service and not having a waiting time or anything. If it's a more acute or more complicated time that needs clinical assessment, it will be longer, and it will, the indication of the weeks and we're on that chart. So it really depends on what their need is. But many of the waits are incredibly short.
So from a teacher's point of view who wants to refer a child, she then has to go through the nurse.
So again, it depends. It depends what service and what need. So there are services where teachers can refer into, but there are services where individual families or young people can refer themselves into, and there are services where they don't even have to refer themselves into, they can just turn up. So many different ways people can get help that it slightly depends on the type of need they think they've got.
Thank you. Helene.
So building on a couple of points that have already been made. So in terms of the Family Hubs part, what we've really talked about here is children and young people's mental health, but a focus around Family Hubs is around parent and infant mental health. And when we're thinking about that early resilience and supporting families early, there's some really strong work around the Family Hubs are building on work of public health, and that should ensure that children have that best start with really parents getting the support they need, and that builds the capacity for children through life, and that's very well evidenced. In terms of the investment, where we've got public health investment, particularly in the REACH model, we're absolutely seeking to move that upstream. And in terms of that evidence-based evidence, we can absolutely draw on the evidence base and the return on investment. And then the point you made, Councillor Maxwell, about understanding what the provision is, Councillor Merson, I've had the conversation, whether it's children and people's mental health, particularly young people who may be in crisis, or adults who are in crisis, there isn't necessarily the shared understanding. And through the briefing programme for counsellors, through some of the training, it may be some of that focus on mental health, and where as counsellors you can pass people on to for support would be something that would be useful for you. And if so, we're happy to facilitate that through the appropriate channels.
Thank you. Helene, David wants to come back.
Sorry, I'd forgotten my one point, which was around the stigma question, which got asked, and we talked about, or you shared that actually we put things out on our social media channels, but are young people using the same social media channels that we're using in that sense? And could we be doing more with our local colleges, so with Tresham, with University of Northampton, around developing comms campaigns with them, testing the messages? I don't even know if Snapchat is still a thing or not, and whether it's something that you're using to get that out there, so that actually it's getting into people's feeds. And
So I think the shortest answer would be our comms social media channels for young people that our comms team put messages out and work on are not the ones I've got on my phone. They're the ones they use rather than the ones I use. So absolutely there. Earlier today, actually, and I was trying to think, and you've just given me a chance to feed it in, when you were talking with Julie and Polly, there's a lot around the social value and the impact and the way of working. We're having conversations, and we have had conversations with University of Northampton and with Tresham College about what other ways can we do stuff, how can we promote both well-being, how can they represent the NHS as a career and a place to be in, as well as us coming along to their things. If you take University of Northampton particularly, it's got an interest in promoting the NHS as a place to have a really good career, because you'll come and study there in order to get yourself a job in the NHS. But testing out the comms models, thinking about referrals. One of the other bits we've done is we've brought together the counselling services, the support services in the University of Northampton, to help them understand where the NHS services kick in and how do we get really good comms between them. So there's an awful lot of communication, both kind of testing out methods, but also how do we provide support to people as well.
The other thing I'd add to that, David, for you is that our comms, and particularly the comms within NHFT, are all co-produced. So the young people will design what the comms look like. iDiscover is a brilliant example of this because it's co-produced from day dot. The young people have designed what it looks like. The young people have designed how it's accessed. The young people have designed how we promote it. And I think that co-production is the real key element to making sure we're advertising things in the right places, because our young people are best placed to tell us where they would go if they were looking for help.
Thank you. I think we've had a really good discussion, and thank you for answering our questions in the way that you have in the presentation. A few recommendations. We recommend as a Health Scrutiny Committee that quarterly to 6 monthly written updates, if feasible, be provided on waiting times for CAMS and other mental health services. This should include a breakdown by service type, e.g. Initial assessments, ongoing therapy, to ensure reductions in waiting times are sustained and any potential delays are addressed swiftly. Our second recommendation is we request an annual review of the implementation of the Thrive model in North Northamptonshire, assessing its impact on access to care, quality of services and mental health outcomes for children and young people, and present the findings of this review to scrutiny by September 2025. And our final recommendation is continued expansion of the community-based initiatives such as the Espresso Yourself Wellbeing Cafes, with an emphasis on evaluating their reach and effectiveness, particularly in terms of engagement and mental health outcomes. There were a few other points at which you mentioned that you'll feed back the digital front door development. It'll be great to get some feedback around that once that's developed. Also, to send the access slide, but I think you've already updated it, haven't you? Thank you very much. You again for your answering questions. Thank you. The next point of the meeting is just for the panel members, so yeah, please feel free to leave. Cheers. The Health Scrutiny Work Plan. Raj.
The next meeting of Health Scrutiny is going to be held on the 12th of November 2024. Following the previous meeting of the Scrutiny Management Board, the 3 items for that meeting will be GP primary care access to build on previous discussion and maintain regular updates, winter preparedness and health protection to scrutinise the strategy around winter protection to vulnerable people, and finally the KGH patient pathway to scrutinise KGH's patient pathway programme and care provision Also, following the previous meeting of the Scrutiny Management Board, we've got quite a comprehensive work plan, as you can see on the screen, lasting all the way to around May 2025. So, as always, if there are any items that we wish to be scheduled, we can add that at the bottom there and try and fit those in where possible. Thank you.
Councillor King.
Yeah, is it possible we can have a look at local hospice provision as well?
Local hospice provision?
Yeah.
As in within the plan?
Within the north of the county, yeah.
Yeah.
Lakeland's hospice in Corby in particular.
Thank you. I'm sure Roger will note that down. Yes, Councillor Maxwell. Thank you.
Is it possible we can then go back to Kettering General Hospital to find out an update to their funding and what exactly are they able to do and what they're not able to do and how we're actually going to move forward, because the hospital clearly needs, is underfunded, but it's not only that, it's outdated practices which is inhibiting people accessing the service which happens there. And whilst it may be satisfactory, it isn't satisfactory because clearly the hospital, which is, I think it's going back 10 years ago, was supposed to be redeveloped, still isn't. So I'd quite like to go back and ask them exactly, what exactly are they doing about it?
Yeah, I agree with you, Councillor Maxwell. I'm sure that's noted. Anything else from any members? Thank you. As you know, these items are discussed in the Scrutiny Management Board, but I'll be taking those forward at the next board. I close the meeting. Thank you.
Thank you.